Again, thank you so much, Dr. Mkembo. Thank you, the team, and thanks to Busoga Health Forum, of which I am a member, and I'm always honored to be part of this forum. And thank you, Liz, for the preamble already given. And of course, Dr. Mkembo, you've actually simplified my work today. So this topic of peptic ulcer disease was, in the olden days, it was for the surgeons, but now it is for the physicians and the medical people. So I'm honored that you brought back this to the surgeon. And so I'm greatly honored. As already introduced, I really need no more introductions, but bring you greetings from Busoga, from Uganda Medical Association, of which I'm a member of the executive committee of the Busoga branch, which I'm chairing the ethics and professionalism. And so for the doctors that are on the platform, if you're not yet a member, we encourage you to join so we can support one another and encourage one another. Already introduced, I'm the CEO of Hope and Healing Center. Many of you may not know it, but I've heard about it. It's just a reminder that we are located in a village in Chiwani. It is in Iganga district, in Nawandala sub-county. When you get time, come visit us, not only for healthcare, but also to chat and get to know one another. I've received many people from the Busoga Health Forum come visit, and I still encourage you to come and visit. Your visit is always encouraging. We of course offer 24/7 care. With any time the clinic is functioning, we have at least a medical officer around, and we offer both inpatient and outpatient services, including surgeries, and we do labs, most of them, both minor and major surgeries, we are doing them, and as well as maternal care and some diagnostics. So enough of blabbing about Hope and Healing Center, but I'm glad and honored to be a medical doctor. Just a brief introduction, but before we go into that, it's more of just the scope of what I'm discussing today. It's the definition, what is really peptic ulcer disease, what is the epidemiology, what causes it, of which Dr. Mukemba has already kind of highlighted, and I will go just a little bit into the gastric physiology and anatomy, not so much, knowing that most of us here on the platform are not clinically, we are other professionals. So I'll put that into consideration so I don't lose you. And we'll look at how it presents, what do we do at the hospital, how do we diagnose it, if surgery is needed, what are the indications, and of course I will give you a take-home message. So as a brief introduction, previously, peptic ulcer disease was one of the biggest indications for gastric surgery. Years ago, during my studying, we used to do what we call vagotomies, and most of the gastric surgeries were due to effects of peptic ulcer disease. But of today, elective surgery for PU is very uncommon. This is due to the development of the anti-secretory drugs, that is the proton pump inhibitors that my colleague Dr. Mkemba has already talked about, and the histamine blockers. Also, we give much credit to the discovery of the H-pylori treatment, of which we shall talk about later. And so now, even with the discovery of the H-pylori treatment, the discovery of the anti-circulatory drugs, still complications occur. And when these complications occur, emergency surgical care is the best option. As of recent and as of today, we still see lots of our people coming in with complications of peptic ulcer disease, and that is bleeding, and it is perforation, which I'll talk about. But like at Iganga Hospital and many of the places that we work at, you find that most of our patients are coming with these complications. So as a definition, many of you, I think each one of you on this platform tonight has heard about peptic ulcer disease, has heard about ulcers. If you've not heard about it, at least you've been a patient, or you've, you know, so it's a common term, and our friends from the herbal clinics are making lots of money from ulcers, and some of them giving us wrong information about ulcers and also their treatment, worsening the outcome. So we feel it important as UMA and as Busoga Health Forum that we come forward and educate you, the public, what really ulcers are and how we treat them, so that you don't delay in seeking care. So peptic ulcer disease comes from the Greek word peptikos, which means able to digest. And an ulcer is a break in the gastric mucosa extending beyond the muscularis propria. Those seem to be big words, but kind of this is kind of our stomach here, and that part, the mucosa, if the ulcer breaks through that, then that is an ulcer. But it is different from an aneurysm, which is a rupture of the gastric mucosa. So they are usually, with an ulcer, it's usually about at least more than 5 millimeters in diameter, while for an aneurysm still is about the same, but one is a break, the other is just a small rupture, but the difference is whether it has penetrated through the mucosa or not. So yeah, in our epidemiology, we know that the PUD, or peptic ulcer disease, worldwide, it affects approximately 4 million people, with an incidence of about 1 to 3%, with a lifetime prevalence of 5% in PUD perforation. But the mortality due to this perforation goes as high as 20%, with 30 and 90-day mortality in duodenal in respect to gastric perforations. Thanks to the discovery of the antacid medication, H-pylori over the years has significantly reduced the complications of PUD due to the discovery of these anti-circulatory drugs and the treatment of H-pylori. So on the next slide, you can see that we give much credit. If you could share for me that slide. Yes, we give so much credit to these two gentlemen that you see on the slide, Mr. Dr. Robin Warren the gentleman in gray hair there, and Barry Marshall. So Mr. Robin Warren was a pathologist in Australia, together with Barry Marshall, who was a clinical fellow at that time. And these two gentlemen won a Nobel Prize in medicine back in 2005 for their discovery. These are the people that were able to correlate the biopsy findings with the presence of H. pylori microbes in causing the PUD. It's fun about that gentleman, Robin. He actually, to prove his point, he had to swallow a cup of Helicobacter pylori, which of course gave him very, very big, a worse case of gastritis. But thanks to his discovery, because of him, we are able now to talk about H. pylori. So there are different causes of H. pylori, of PUD, which most of it being, of course, the H. pylori, then the non-steroid anti-inflammatory drugs like the ibuprofen and the aspirins, and of course the smoking, alcohol, and all that, and then some of them being the malignance, and then extreme stress. But before I talk about that, extreme stress for some of us in surgery and in medical practice, we see some of those being the Carling's ulcer, which is caused by stress by severe burns, while the Cushing's ulcer for people who have had a severe head injury. But that is when you are within clinical practice. Now, what is H. pylori? H. pylori is a gram-negative growth, and it is nasty as it looks there. It has those flagellae, as you can see that slide. But this bacteria affects about 50% of the world's population, with it being transmitted through things like vomit, stool, saliva. There are controversies about infection through drinking water and food. This has been very controversial. Some people say it's transmitted through, contaminated drinking water and food. But of recent, there's a lot of controversy in regards to that. But what is important for now is that this H. pylori causes at least 95% of the duodenal ulcers and 70% of the gastric ulcers. What is the mechanism? I will just briefly go through that. How does it cause that? Firstly, it has the flagella, which allows it to travel from gastric lumen down to the gastric epithelium. And then secondly, it has an enzyme called urease, which allows it to convert urea into and water into ammonia and carbon dioxide. Now, the ammonia helps it to develop protective mechanism to withstand the pH of the stomach. Then this, it also has the other things it produces, that like the enzymes that contribute to cell death within the stomach. So with this, just a brief of that is that with its presence there, it will now start, causing or eating up part of the protective mechanisms of the stomach lining, hence leading to the ulcers within the stomach and within the duodenum. As we go to the next slide, the diagnosis is quite simple. for ulcers. And we can either go invasive or non-invasive. The invasive is part of what Dr. Mukemba has already talked about through doing an upper GI endoscopy. What is that? It's just a small tube that they pass through your mouth down to your throat, down to your stomach, and part of the small part of your intestine called the duodenum, to see whether there are these ulcers or aerasions or not. And so during endoscopy, a sample is taken off, or what we call a biopsy is taken off, and then testing for H-pylori is made. This is very important, that when endoscopy is done, especially for lesions or erosions within the stomach or ulcers within the stomach, that some of them can be, it's a cancer that is causing the aerasion or the ulcer. So this biopsy is very important, and it is the gold standard for diagnosing PUD. But also there are the non-invasive methods where we easily do H-pylori test. You can use the stool test, which is more accurate than the serum test. But also we have the carbon-13, the breath test, which is done. And our friends, I am not so sure Dr. Bwanga is on this, but he has done a great job in helping us in diagnosing peptic ulcer disease. So we can go on to as we go on to the next slide here, not to bore the rest of the non-medical people with the anatomy, but gastric ulcers or stomach ulcers, basically most of them occur around the lesser curvature, most of them. And the duodenal ulcers are 4 times more common than the gastric ulcers. Now, the duodenal ulcers happen just at that first part of the duodenum, but the gastric ulcers, it is clinical recommendation that whenever you find a gastric ulcer, it is important to biopsy it to rule out a cancer of the stomach. Now, there are different places where the gastric ulcers can happen. They can either be at the antrum, which is common, but there are also those that we call hyroid, which are usually difficult to treat. They are towards the cardia, if you see towards the esophagus there, and those usually bleed much. And the surgical management depends on where they are. For example, those that are in the antrum, just a simple wedge resection can easily be of help. But to some, depending on how severe it is and how blood they are, then someone might need what we call a gastrectomy, either Biroth 1 or Biroth 2. But we won't go into those complications and those big terms as for now. Request that we go to the next slide. Thank you for sharing my slide, Busoga Health Forum. So yeah, as part of the physiology, what is important for the doctors that are here, I know that many of you have diagnosed peptic ulcer disease, but I also know that many of you have got some of these patients with complications of bleeding, but also perforations. It's important, very, very much important, to get to know the anatomy and the physiology of the peptic ulcer disease. What is important in this slide is the important structures that are around the antrum and the lesser curvature, because that's where most of them happen. Yet we have very important structures like the gastroduodenal artery that you see there, and yeah, the right gastric artery as well as the left one. So it is important to understand these structures and to understand the physiology. Why? The reason as to why it was the most common gastric surgery before for peptic ulcer disease is because many people used to do the truncal, the vagotomies, and the resections, because they thought that would be, you cut off the mechanism of the secretion of the acids here from the vagus nerve. But now that the discovery of H. pylori treatment and circulatory drugs have, have come into place, now we less do most of these surgeries. What makes us to do the surgeries mostly is the perforations or bleeding, as we shall see in the next slides. So how does it present? My colleague Robert has already done a good job for me. Epigastric, peptic ulcer disease, or ulcers in common, which you all know in common, is easy to diagnose, is easy to tell, and anyone can at least have a clue on this, even when you're not medical. It is usually an epigastric pain. Epigastric, like Mokembo said. Thank you, sir, for saying that. I was looking for, how do I now describe this? It's just pain, just below your chest, above your stomach, above your belly button, or above your what? So it's upper part of the stomach, and the pain is usually burning in nature. But how do you tell whether it's duodenal or it's gastric? With duodenal ulcers, they start usually they're worse before meals and usually at night. It's burning, and when you eat something, they are relieved by eating. While for the gastric ulcers, they are worse on eating, and so we find most of the patients with gastric ulcers that they present with weight loss because they fear to eat. Anytime they eat, it's worse. And they are usually relieved by the antacids that we are talking about. While for the perforation, it is usually a sudden onset of abdominal pain on a history of a patient who has been having, this burning epigastric pain. Possibly they have been taking some antacids, or they have been taking some omeprazole here and there, and then they have this sudden onset, and the patient will easily tell you that, it just started abruptly, it's burning in nature, and then they present with what we call in medical language peritonism, and a body-like rigidity. The stomach is hard. They don't want you to touch anything to do with the abdomen, and they are really in pain. So once such a patient presents in the clinic, or you have a relative of that kind, it is important that you first of all think about peptic ulcer disease. So once a patient presents with those symptoms, how do we work them up? What do we do for us to get to know whether it is what we are thinking or something else? One is we take off blood to, first of all, do the full blood count. We want to see the hemoglobin level. Is it low or is it within normal? Is the urea high? Because when it's high, usually it gives you a picture of hemorrhage. But what is important is that this blood test, you can do the C13 breath test, or you can, the H. pylori test that many of us know. If you have the time and it's in an elective case, you can ask for stool to do a stool antigen test for H. pylori. In case of suspicion of a perforation, it's important, very much important, to do a plain, erect abdominal X-ray, or sometimes we say erect chest X-ray. This sometimes can be negative depending on who has taken it, how they have taken it. But with this chest X-ray, we always request the radiologists that they let the patient, if they can, to sit up or stand up for at least 20 minutes before they take the chest X-ray. But if they are unable to stand, they are very sick, then they will lie in the left lateral position, and the radiographer will take this X-ray. And the reason for that is for us to be able to see air under the diaphragm, that is, if they are perforated. CT is less sensitive, and in our setting, it is not something that you run to as a first option, unless the rest you can't get a picture. But it's unlikely in our setting that you should ask a patient for CT of the abdomen. That is really unlikely, and it is not good clinical practice that you should ask for that if you're suspecting peptic ulcer disease. However, the gold standard for diagnosing or getting to know whether the patient has ulcers or not is endoscopy. Endoscopy, you can forget everything I'm saying in this presentation, but don't forget endoscopy for you to know and to tell whether you have gastric ulcer or peptic or duodenal ulcers. Please do an endoscopy, and they are now becoming more common with our friends Chabira Surgical Center, of course, doing them at a very cheap price. So please do it, and through endoscopy they are able to take off a biopsy to check for not only the malignancy, but also to confirm that diagnosis. Medical treatment, I really don't want to go into much into the medical treatment. Yes, please go ahead, Benjamin. I don't really want to go much into the medical treatment. As already explained, it's very easy once we've known that you have peptic ulcer disease. Before, it was a proton pump inhibitor combined with actually metron and amoxicillin. That was before. Now, due to abuse of the medication, due to overuse of the antibiotics, we no longer use amoxicillin because already it developed the resistance. I have sad news to say that even for clarithromycin, which is right now still being used through our pilot kit, our friends, Dr. Bwanga with the team, did a research of recent, and they found that still there is now resistance to clarithromycin, which was a very good drug. But the gold standard, usually the medical treatment, is that you combine a high functioning proton pump inhibitor, that is like omeprazole, that many of you know, or lansoprazole or esomeprazole, and then you combine that with 2 antibiotics. And so one of them is clarithromycin or plus tinidazole. This is taken for 7 days. But you continue with a PPI to 14 days. The antibiotics end on 7 days. The PPI continues to 14 days. That is the guideline. And then all patients should be tested before you treat for H-pylori, because this regime that we are talking about is basically for treatment of H-pylori and then to cover the gastric mucosa. So it is important that you first test to confirm whether they have the H-pylori or not. But now, after that regime is given, it is advised that 4 weeks after completing treatment, Then you repeat the test to see whether it's still active or not. Now, there has been problems that most of the patients, you recommend them to test, but they are still taking the PPIs. You're likely to get a false positive or a false negative. So it's important that the patient stops 2 weeks beforehand for you to get the right diagnosis. 2 weeks, they stop taking the PPIs before you retest. So this is now where the surgeons will come in. After our friends, the physicians and the rest of the team, they have managed the ulcers and they have possibly worsened, or our herbal team has given all the jerry cans of the herbal medicine. This is the picture that we usually get, either bleeding or perforation as the major complications of peptic ulcer disease. The obstruction is really less, it's about 3%. Then we have intractable disease and sometimes a suspected malignancy or suspected cancer. But we will talk about bleeding and perforation as most of the complications, which lead us to actually do the surgery. Next slide, please. Yes, so what are our indications for surgery? It's usually failed endoscopic therapy. So we know that for bleeding ulcers, which is one of the indication, there are just 4 folds the indications for surgery is failed endoscopic therapy, hemodynamic instability, that is a patient is losing over 3 units of blood, and then recurrent hemorrhages after 12 attempts of endoscopy. And then you notice there's a continued slow bleed requiring at least 3 units of blood. Such a patient, you really need to counsel them to consider surgical management. Please, to the next one. As in what is done in surgery, with endoscopic intervention, usually they do an embolization, which is not common here in Uganda, but sometimes with surgery, you go in and clip, excuse me. You go in and clip the bleeding vessels. But once that fails or the patient is unfit for that, then surgery is the mainstay. And what is done in surgery is still you open up the patient and find where the bleeding is. And as we remember before, the anatomy and the physiology is important because that's when you'll go and check which part of the stomach or which part of the duodenum is bleeding, and you go in and directly stop the bleeding through surgery. The same happens for the perforations. Could we go to the next slide? Yes, the same really happens for perforations, but the goal is hemorrhage control. Stop the bleeding, then reduce the acid, which we already do with covering the PPI. But that approach is usually determined by the surgeon. Where is the bleed or where is the perforation? So once you know where that is, the rest is managing. So for us as surgeons, we always go in, see where the problem is, take care of the problem, come out of the patient. So for posterior wall ulcers, that is you need to expose the ulcer. And so sometimes you might need to do a duodenotomy or a duodenopyromyotomy, which is a difficult surgery, and you need to know where you are so that you don't cause more danger. And then you do the direct suture ligation. Sometimes you may have to do a gastroduodenal artery ligation if that is necessary. Now, for the perforations, if you find that it's a perforation, depending on the size, it is important that you freshen the place where the perforation was, and then you do the suturing just as you see. This is mostly for our friends who are doctors on this forum. We believe that all of you can save a life of the patient. You make a longitudinal incision, or yes, as you freshen that, but when you are suturing, you do a transverse suture. And then with that, it's always recommended that you can do a Graham's augmental patch, aumentoplasty, or you put a Graham, you put augmentum on it. But if you cannot, maybe you are not able to see the augmentum, then you are able to look for the fresher edges to do that. But in case you're not able to do all that, and so for example, it's a gastric ulcer, you might need to do a bypass to save the life of the patient, because most of these patients that are coming, they are really sick, so you may not have the time for the gastrectomy and these major surgeries, but at least you can do a bypass, wash the patient very well, and come out as soon as possible. So again, as I said, if it is within the antrum, you do a wedge resection, or you can do a Billroth depending. But if it is a high riding, you might have to do a Billroth 2 or a subtotal gastrectomy. That is if you are able, it is within your means and you can. If you can't, please wash the patient, put an NG tube in, put make sure that you've washed this patient, you've freshened the edges, make sure that there's no more bleeding. You can even do a damage control surgery and then go back in for that patient. What is our take-home message for tonight? One is that the duodenal ulcers are more common than the gastric ulcers, and H. pylori is a major risk factor, which usually requires treatment, and it is medical treatment. For any bleeding ulcers, our first line diagnosis and therapy is endoscopy. And if the bleeding is uncontrolled, if endoscopy fails, then please go in for surgery. And for all unstable patients, it is more advised that you do surgery than endoscopy or laparoscopy. Thank you very much.